Good morning, everybody. Thank you so much for joining us for this webinar, Bring Your Own Breakfast webinar, about how you and your clients can be part of the CanTreatCOVID clinical trial. Just going to wait another minute as people filter into the room from the waiting room. Okay, it is 8:03 and it looks like people have stopped filtering in from the waiting room. So we are just going to get started. Sarah, can you make sure we're recording?
So it looks like from my end, it has to be you recording.
Okay.
Oh, I can send a request.
I think we're good, Catherine. I can see it.
Perfect. Thank
Okay,
you.
perfect.
Good morning, everybody. Welcome and thank you for joining us for this webinar presentation about the CanTreatCOVID clinical trial and how you and your clients can participate. The Alliance for Healthier Communities is hosting this webinar in partnership with the CanTreatCOVID study team. I'll be introducing our panelists in just a few moments, but first, let's take a moment to review our housekeeping and acknowledge the original stewards of the land where we are virtually gathered. So this housekeeping will be fairly quick because most of you are Zoom pros by now. We are recording this webinar, as you probably just heard, and we'll share a link to the recording along with the slide deck later this afternoon or tomorrow morning, so please watch your email for that. There will be a Q&A and discussion period at the end, so please feel free to submit your questions in a Q&A panel, and you can type those at any time as soon as you think of them. We'll ask them on your behalf and do our best to group them thematically. We've also set it up so you can comment on or upvote each other's questions, so feel free to do that. If there's a lot of questions, we'll prioritize ones that seem to be on a lot of people's minds. However, this is a pretty small group, so we should be able to keep things fairly conversational. If you'd prefer to ask your question out loud, you can use the raise hand function, and then we'll unmute you and call on you. But please do remember to mute yourself afterwards so that we can keep the background noise to a minimum. Now, I'd like to get us started in a good way by acknowledging the original stewards of the land where we are virtually gathering today. My name is Catherine, and a little early in the morning for me. We recognize that the work of the Alliance for Healthier Communities and our members takes place across what is now called Ontario, on traditional territories of Indigenous people. They have lived here since time immemorial, and they have deep connections to these lands. We further acknowledge that Ontario is covered by 46 treaties, agreements, and land purchases, as well as unceded territories. We are grateful for the opportunity to live, meet, and work on this territory. Ontario continues to be home to vibrant and diverse Indigenous communities who have distinct and specific histories, needs, and assets, as well as constitutionally protected and treaty rights. We honor this diversity and we respect the knowledge, leadership, and governance frameworks within Indigenous communities. In recognition of this, we commit to building allyship relationships with First Nation, Inuit, and Métis peoples in order to enhance our knowledge and appreciation of the many histories and voices within Ontario. We also commit to sharing and upholding our responsibilities to all who now live on these lands, to the land itself, and to the resources that make our lives possible. My name is Catherine, and I am a settler here. I live and work on what is now called Toronto. This is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and it is now home to many diverse First Nations, Inuit, and Métis peoples. Toronto is covered by Treaty 13 with the Mississaugas of the Credit. So now a quick introduction of today's panelists. These will be familiar faces for most of you. Dr. Jennifer Rayner is Director of Research and Policy at the Alliance for Healthier Communities. She has a PhD in epidemiology and biostatistics and is an adjunct research professor at the Center for Studies in Family Medicine and the University of Toronto in Family Medicine and with the Institute of Health Policy Management and Evaluation. She has worked within the community health sector for over 20 years and is interested in comprehensive primary healthcare, interprofessional teams, and health equity. Dr. Rayner was an advisor to the Ontario COVID-19 Science Advisory Table. Dr. Andrew Pinto is the founder and director of the Upstream Lab, a research team focused on tackling social determinants, population health management, and using data to enable proactive care. He holds the CIHR Applied Public Health Chair in Upstream Prevention. He is a public health and preventive medicine specialist and family physician at St. Michael's Hospital in downtown Toronto, and an associate professor at the University of Toronto. He is associate director for clinical research at the University of Toronto Practice-Based Research Network, Utopian, and the lead for artificial intelligence in a new initiative at the Department of Family and Community Medicine on how new technologies will change healthcare. And with that, I will turn you over to Dr. Pinto. Welcome, and thank you so much for being here.
Thank you so much for having us, and really appreciate the invitation to speak. It's been really wonderful to work with Jen and Sarah and others at the Alliance over a number of years, including on this project. We can go to the next slide. So I appreciate the land acknowledgement that was done, and I just want to also begin by acknowledging that the Upstream Lab is located in Toronto, which is the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississaugas of the New Credit. Today, Toronto, of course, is home to many Indigenous communities from across Turtle Island. It's covered by Treaty 13. And whenever I give a presentation, it's a good reminder to think about the calls to action and take action on them, specifically those that are targeted towards the health sector. Next slide. So this is a large project that has been supported by an unprecedented grant from CIHR, or Canadian Institutes of Health Research, Health Canada, and has the support of the Public Health Agency of Canada. And something that we'll come to kind of towards the end is that this is a kind of a unique opportunity to evaluate the effectiveness of medications, in this case to treat COVID, without a drug company involved. So all of the funding is from public sources and is our tax dollars to support this type of really important study. Next slide. So why are we doing this research? We're now 3 years into the pandemic. And many may ask, why are we doing this type of work now? Well, most of the research on what is effective for treating COVID has been in those who have been sick enough to be admitted to hospital, people who have been hospitalized or in the ICU. And most of the studies have been in people who are unvaccinated. So right now, we actually are not sure which therapeutics are effective to treat COVID in people who are partially or fully vaccinated, as is most of the Canadian population, and people in non-hospitalized settings. And no therapeutic has been evaluated for its potential in reducing the likelihood of long COVID. Next slide. So what are we trying to learn? We're trying to examine a variety of treatments for COVID when people are sick with COVID to see, is the treatment effective at reducing how sick people get? Is it cost effective? Is it a good use of public dollars? Some of these medications are very, very expensive, and there could be other uses of those funds. We're also looking to see if any medication reduces long COVID. And are there any differences amongst different populations? For example, people who are partially vaccinated versus those who aren't, people who identify as women versus men, and so on. Next. So what are we doing? CanTreatCOVID is evaluating both the clinical and cost effectiveness of treatments for mild to moderate COVID, meaning COVID that people get which doesn't land them in the hospital. We're building capacity through this study to really support primary care research in Canada and to create evidence that's going to be relevant to our work in clinical settings, but also in the future. One of the things that we'll maybe talk about in the question and answer session is that we're also seeing this as a chance to really build an ongoing system to be able to help prepare us for future pandemics. And one really important thing with this study that we've been mentioning whenever we talk about it is every participant and person involved in this study is assessed by a clinical pharmacist and is closely followed. They actually receive much closer follow-up through this project than they would in usual care, because we have staff who are touching base with them and checking in very, very regularly. Next slide. So what are we looking at is looking at usual care if somebody gets COVID and just has general supportive measures versus new and existing treatments for COVID. Our first arm that we're starting with is Paxlovid, and I'll talk a bit about that and the evidence around it, but we will be adding additional arms and additional treatments to the study. Next slide. So who could participate? It's a very broad group of people. So people need to have had a positive COVID test, whether it's a rapid test or a PCR testing, and they need to be part of this within the first 5 days of when their symptoms start. And they need to be either 50 and older or between 18 to 49 with one of a large number of pre-existing conditions. Next slide. And these are that list of conditions. So you can see it's quite a long list, and many of the patients that we care for will have one or more of these conditions. I know from a number of years working with colleagues in community health centers that you see many people who have higher burden of these types of conditions. So I suspect this would be quite a lot, or even the majority of patients. Next. And in terms of our exclusion criteria, things that would mean that someone wouldn't be are kind of common sense. People who are already admitted to hospital wouldn't be part of the study. People who are essentially admitted to hospital, but they're waiting in the emergency department for more than 24 hours. If someone has already been part of the study, if people are already part of a study that's testing, treatments for acute infection. If they've already taken this, so if someone has already, for example, started Paxlovid, or if there's some contraindication, part of our process is really carefully checking to make sure there are no interactions with existing medications, or if they couldn't provide consent. So what does it involve? What happens is people contact us. They're often, the majority of people who are joining the study have been referred by their primary care provider. So we know that this is probably going to be the main way. You may have also seen ads in the subway if you're in the Toronto area, or you may start to see social media posts about the study. So we're using a variety of ways of letting people know. But right now, primary care providers who tell people about the study is the main way people are coming to us. People, we'll just go back. People, who come, they speak right away with a member of our team. We have a 1-800 number. We have an online form that people can use to connect with us. And we reach back to them right away, and we pick up the phone. We ensure that they understand what this study is about, and then they actually speak with a pharmacist to go through medications, and then they're randomized. So they could be randomized right now to usual care, which is supportive measures, or an intervention arm. Our first intervention arm is Paxlovid for 5 days. The reason that we're starting with Paxlovid is that there is a lot of questions still about this medication, including whether or not it truly is effective for people who have been vaccinated and people who have mild infection. Many of the people who work clinically, or if you've had a family member or yourself, you may know that we are seeing Paxlovid given out. it's based on the evidence that was mostly done in studies where people were unvaccinated. So there's a lot of questions still to be answered with Paxlovid, but we will be adding other options as well. The study is fully remote, so people can participate from home. We know that this has worked out very well, where we connect with people, they do things online or over the phone with staff, and also we send the medication directly to somebody's home. Now, one of the things I'm sure that we'll talk about in the Q&A is, what about people who are experiencing homelessness or people who don't have a phone? We are very eager to work with organizations to help support people. We can do things like have people use a phone at a center, and also use the mailing address of a center or pharmacy. We can be really flexible around that. Next slide. So why would anyone refer people to this study? One big reason is that it can ultimately save time for clinicians. People are monitored very closely. People have a lot of time with staff to answer any questions they have. We make sure people are fully aware that it's a randomized trial. So it's like flipping a coin in terms of whether or not they would be on which treatment arm. This is the fastest way that we can answer whether or not these medications are effective. And this is really important for Canada and for other countries that have spent hundreds of millions of dollars on these medications, and also are relying on them, not just for now, but for future pandemics. And also, as I mentioned at the start, we have no ties to the pharmaceutical industry. This is a very rare example where a study is being done with public dollars and not relying on the drug company. In fact, the initial studies of, for example, Paxlovid that everyone is relying on were fully funded by the drug company. And we know that from past experience that can introduce biases to the study. In fact, one of the key studies that was done by the pharmaceutical industry, they didn't share the results as yet, and they have just put out like a press release about it. So this type of publicly funded research is really, really key. And what's kind of neat with this is by primary care and for primary care. So myself and many of the people involved work in primary care and are seeing this as a chance to really finally create a living kind of network in Canada to do these types of important studies. Next. So how could you support us? We would love if you, for any patient who has acute respiratory illness, for you to first consider COVID. I work in a clinic where I'm often working with residents and other colleagues who are training, and I'm noticing a lot of people are actually kind of forgetting to think about COVID, and they're not doing like even rapid tests, even though there's a whole box of rapid tests sitting right there. So don't forget to test and think about it. And what can help is if clinics actually, anybody who has a respiratory illness is put in isolation, and then a test is done, and then it's available for the clinician right then. And so implementing like a standard approach could help, and then letting people know that there is a study happening. They could be part of it. There's honorariums for people's time, and you're closely followed while in the study. And a lot of patients, we know a lot of people living in Canada actually really want to support science, and particularly publicly funded science like this. Next slide. So next steps are, we're aiming to identify one point person at each site who would be a local site investigator. We would invite that person to be involved, to grow their experience too of being part of research, if they would like to be part of the grant, part of the papers and reports. But that helps a lot to have one point person who can be involved with helping ensure that posters are put up, that postcards and stickers are available for the clinics, and we would support them through that. We do have Research Ethics Board approval for this already, which covers the community health centers, and we've worked really closely with Jen, Rayner, and Sarah on that. And we would report progress and outcomes to all the participating clinics. And we also see this as the chance to be part of the start of the Canadian Primary Care Trials Network. So this will be a network that engages primary care sites to be part of creating knowledge about whether different interventions work, and will really be in the real world of primary care, not in super subspecialized areas, but actually generate the evidence we need for our work day to day. Next slide. And so this is what the posters look like. Again, if you're in the Toronto area, you may have seen these on subways. And these are the types of things that we would put up. We would change the logo at the bottom from St. Michael's, where I'm based, to the relevant center to show that there's that support. Next slide. So I'll just end here, which is how to refer people. Please do take a look at our website. You can consider bookmarking it. You can start referring people right away. And you can just let people know if you have a family member or a patient or other who gets COVID, you could say, hey, you may want to check this out and consider it. And again, we know that that's been the best way for people to hear about and to be referred to the studies. I'll end there, and I see there's a really great, interesting question that's in the Q&A already, which is, should long COVID be added to the list of pre-existing conditions? That's a really interesting question. We know that now something like between 10 to 15% of people who get COVID actually have persistent symptoms. And we know this is going to be a really big challenge as COVID stays with us. It will become very similar to influenza, something that it comes around and that sticks around. So the reason we didn't include long COVID in this is long COVID itself is still such a new entity in many ways that the existing at the time when we developed this study, which is now over a year ago, that it wasn't seen as something that would increase people's chance that they would end up being in hospital. But it's a great question and something that I'll bring back as just something for us to actually look at, which is people who have experienced long COVID. Are they at more risk of ending up in the hospital or the emergency room or death? We know that people who experience long COVID are more likely, if they get reinfected, to have persistent symptoms. It kind of is an additive type of thing where if you get infected multiple times, it increases the likelihood that you develop long COVID. But it's a really interesting suggestion. Yeah, we could probably take down the slides too, and we could just open it for questions. And I know that Jen is also going to help with moderating them too.
Hi, thank you so much, Andrew. And along with Jen, we've also got Gillian, who is a member of the study team from Upstream Lab. She's here as well. So, please do, type your questions into the chat or Q&A panels, or just raise your hands. We're a small enough group, but we can do this in a pretty interactive way.
And for sure, Gillian, if there's anything that you would add to what I said, please, to speak up.
Thanks, Andrew. I'm going to pop the link for our newsletter of the CanTreatCOVID study into the chat just now.
Maybe while people are thinking about questions, one thing I'll add is that Jen and I have spoken for a number of years about how to also use chances like this to engage people who are working in alliance organizations who are interested in research. This is a great opportunity to join a group, to kind of learn by being part of it, to grow in their kind of experience, and to bring research and this type of inquiry into CHCs and other members of the Alliance. And so very, very welcome to that. We really were a very close community, I would say, in primary care research, where there's a lot of support for people. So even if people have never been part of research before, this is, we're very supportive and want to support people to every year. There's a few colleagues that I speak to who are working in community health centers who are asking, like, how do I get involved? And this is a good example. There's a question in the chat about the number of doses of the vaccine, which is good for people. This is a great question. We know that in Canada, we have one of the highest rates of vaccination, which has been a good thing. About something like 83 to 85% of Canadians have had at least 2 doses of their vaccine. So that's a good thing. What we're seeing now is that the vaccines are very effective, but that we need boosters as well. So what I've been recommending to patients is, the first is, the Ontario government website for COVID vaccines is very good to help people understand their own where are they at right now. So people can go there themselves and kind of actually plug in their information, and it will tell you are due for a booster or not. But a simple kind of way to think about it is, if it's been more than 6 months since you've had a vaccine, likely you're due for one. And you should get one, particularly if you're amongst the large percentage of Canadians who got 2 doses of a vaccine but never got any more. And it's been quite a while. I have a lot of patients who the last vaccine they got was in 2021 or so. Then it's highly likely you're due, because you didn't get the bivalent vaccines, which have been available since the fall. So you should get one. And then what we're probably going to be going to is, starting with this fall, is similar to influenza, where once a year you get a COVID booster that is tailored to the circulating strains that we're seeing, and that you would also get an influenza vaccine. So that's probably where we're headed, now that there's a fairly high proportion of the population that has natural immunity from getting COVID, as well as has had a number of vaccines. But the actual number of doses varies based on things like age. Were you amongst that group of people who are 80 and older, 70 and older, who got vaccine? Are you immunocompromised, and so you were recommended to get doses? So I have patients and family members who have had, say, 5 or 6 doses, and I have some people who have only had 2 and should be getting another one. But thanks for that great question.
Thanks, Andrew. And now Ontario is the first province, I understand, that started recruiting clients for this, right? Have you had a lot of participation so far? How has things been going?
Yeah, it's true that Ontario has been the first province to get approval and to get everything organized. The other provinces are very close behind. They include British Columbia, where we're just waiting on kind of the final ethics approval. Alberta, which has already been kind of approved, and they're just getting kind of things together. Manitoba, which also has already been approved. Newfoundland, which is all approved, and then Quebec. So those are the provinces involved. Collectively, those 6 provinces cover about 90% of Canada. And in terms of the progress to date, it's been slow. I think like any project which relies on people reaching out and seeing a poster in a subway or a primary care provider thinking of it, it has been slow. And so we know that to do this, to get to where we need to, it's going to require a huge effort. And in Ontario alone, we're envisioning engaging hundreds of primary care clinics, which will be large academic sites that are connected to many of our universities, which are all involved with this. It'll include smaller, community organized centers. It'll involve outreach to pharmacists, which we've done. We've actually sent notifications and to every pharmacy, over 5,000 or so, like pharmacies in Ontario. So it's on a really large scale. I don't think there's been a a trial in Canada of this scale. One of the things, though, too, is all of this investment and effort is also about preparing us for the future. So we're really already starting to think about how can we use this to help support better surveillance for respiratory illness and new viruses that are going to emerge in the future. And also potentially see this become a platform to evaluate treatments, not just for COVID, but also for influenza and RSV, where we had a really rough RSV season this year. And as many will know, we have no treatments for RSV. So that's kind of into the future where this type of investment will help create kind of an ongoing way to help us across Canada in primary care better identify a virus when it emerges, and also quickly be able to identify treatments that could be used for treating these different infections.
Thanks, Andrew. And I'm wondering, for those who are here as attendees on the call, we do have people from a mix of different settings. I'm wondering if anyone on the call is comfortable to, raise your hand, and we can call on you to maybe talk about what are some of the barriers that you may be experiencing to getting some of your clients involved in this study.
I can offer to fill the air of it because I've been out in community. I'm the community engagement specialist on the team, and I've been out and visited some CHCs, and I come from a CHC background as well. So yeah, one of the things, of course, is as you had already mentioned in clinical setting, Andrew, people aren't thinking about COVID. I've talked with leaders of some of the teams, the vaccine teams, and some of those vaccine ambassadors, which, by the way, as many of you may know as well, the funding for that is wrapping up this week. So there's kind of this wind down around COVID, which creates a challenge for engaging people thinking about it as something that's meaningful for community health or a priority. And so I think that this study is sort of an opportunity to continue to remind ourselves that COVID isn't the only threat to people's health, but it is among the threats to our well-being, to community well-being, and it continues to be an equity issue, right? Those who are currently suffering from COVID, we know, are disproportionately also suffering from systemic inequities. And so framing it that way, that's certainly how I frame it myself. And looking at even how maybe in your community setting, because I know not everybody's from like a community health center who's part of the Alliance, but in your community settings, how can this partnership on this research be a part of your collective work around supporting community wellness and engaging community members in learning and also in becoming part of a scientific project. We do have, and that's why I put that newsletter in there, and Gail's put it in the chat. She's our communication specialist, that we have posters, stickers to go on the RAT tests, the rapid antigen tests. So in communities, even in non-clinical spaces, people have very much welcomed that, to be able to provide that. And then also just knowing that the monthly newsletter, which Gail puts time into every month, is also about, hooking anybody in. It's not just for clinicians, it's for community as well. So I encourage you to think of engaging anyone. One of the challenges with our study is that small window of 5 days. And so the newsletter is a way for us to kind of stay connected and share other information related to COVID and caring communities. So just saying that's one challenge I've noticed, and one response that I've been bringing to it.
And I just wanted to note Amy put in the Q&A that, yeah, many COVID assessment centers or cold and flu clinics are closing up. We know that that's the case. So people, it is becoming harder to identify people. We are still seeing people coming into clinics, and we know that this work that we're doing now is also about building our preparation for the fall as well. So we're as a group, we recognize we'll see declining COVID over the spring and summer as there's less people indoors, and then likely there'll be a surge in the fall as similar to the flu. Another really great question was someone mentioned that on our clinicaltrials.gov site, which is where we registered the trial, that we had noted January 2024. And I wrote an answer, which is, it's really a really good question. The clinical trials registration system is set up for more traditional trials, so you have to specify an anticipated end date. And January of next year would be, as our hoped goal to reach at least 2,500 participants. But as an adaptive platform trial, it's actually set up to be ongoing. So we would, as we get to the fall, we would just extend that date and keep on doing it. So an interesting thing with these types of platforms is that they're very well suited for this type of issue, which is an ongoing kind of evolving pandemic and where the virus changes over time. So it's really useful to have this kind of ongoing thing. And yeah, I as Charis has put in the chat, that I think we're all seeing that many patients are not testing for COVID. There's been a bit of, I think, as Gillian was mentioning, there's a bit of, we all want to put this in the rear view mirror and kind of move beyond it. But we are still seeing lots of people get COVID, and it sometimes have quite severe consequences. So that's where I think reminding patients and community members to test for COVID, to think about it, because there could be things that they're eligible for. It actually does lead to things like persistent symptoms. Something that I've seen as a clinician is people presenting to our clinic with persistent symptoms of like a cough or shortness of breath or chest pain, that when we talk to them, it traces back to what was likely a COVID infection, but they didn't test at the time. But they have all the signs of that you had, like maybe 3 or 4 or 6 weeks ago, you had a bad cough and cold and fever, but they didn't do a test, but now they have persistent symptoms. And our best guess is likely that it's long COVID that they're experiencing. Thankfully, most people recover from this, but it's something that worries me a bit, is that people who are seeking to claim, say, time off from work or insurance claims for long COVID, if they didn't do a COVID test, it's very hard to show that it is indeed long COVID. So I think encouraging people to remember that long COVID is a real issue. It affects quite a large number of people, 10 to 15%, and that they should do a COVID test. And that rapid tests are available through our clinics and also through places like pharmacies and as well still, and that they are still free, and they should pick up a kit and have some as well.
Thank you. Andrew or Gillian, do you have any questions for the attendees?
Yeah, and I'm sorry to hear from Nina that you've had long COVID. It's really a significant challenge. We have some of our patient partners who are supporting this study, who are people who have long COVID, and they're really motivated to see this study through, because we could identify things that help reduce the likelihood of long COVID. In terms of questions, I don't think there's anything that comes to mind. I'll turn it to Gillian. I think thinking and hearing from people about any challenges or barriers and solutions that they would have would be great. I think our next step will be working with Jen and Sarah, and both Gillian and I have had the privilege of working with a number of community health centers in the province, is reaching out to them and saying, you know, would you like to support this? And if people reach out to us, I suspect we'll start to see where maybe across the alliance, maybe, you know, we start with, you know, 20 or 25 centers that are saying we would like to be involved. And that also this leads to a discussion about engaging centers and people and growing their research experience and you know, how to use this for that.
Yeah, I mean, I'd love to ask a few questions. I'm always curious because I came from the health promotion side of things. So just like who's on the line, you know? And so feel free to just throw something short in the chat. It's just nice to know where are you from? What organization are you from? What part of the province are you from? What do you primarily spend your days doing? What kind of setting, clinical or community? So that's just nice for us to know in terms of who's been able to make the time and taken the time to show up this morning. And then my question, I was just, I was recently at a community center, but Access Alliance was part of a partnership, and there was a nurse there doing, can't remember, you know, they always have different names, but basically getting out to where people are at with health services and health information. And so that's a very clear place where we can address some of this concern about the knowledge and the dialogue about COVID sort of diminishing. And so I just wanted to ask if anybody has any of those kinds of programs. If you're familiar with what I'm talking about, like just taking, you know, doing the blood pressure, but mostly information and referrals, that kind of navigation out in the community space, because that is somewhere where certainly it will make a difference. And with regards to the RAT tests, some community organizations still have them and some don't. And as Andrew said, this is a longer term study. So we're looking at how to hopefully in the fall be able to, as well as give stickers out for people's tests, also for organizations that don't have access to them. I presume all of you would, but outside other community groups. So also, please have, I'll put my email in the chat, but please have any community partners that you work with that might be curious or concerned or having experience with COVID that makes them want to get involved. They could reach out to me. We're also partnering with community groups.
And I was just saying, oh, sorry, Andrew, go ahead. I was just going to
yeah, go ahead, Jen, and then I'll turn to the questions. Yeah.
Perfect. I was just going to add too, like we've been trying to really promote this project through our bulletin and through our Epic News, and I've sent individual letters to the executive leaders. So I think also if you've got networks, you know, please share this, because, you know, I know everyone is so stretched when you talk about barriers. I mean, we're having a hard time getting folks, I mean, just to have the energy to, I think, you know, be able to manage their day to day. So taking on extra work just seems a bit insurmountable, I think. So if folks could share this, and, you know, myself or Andrew or Gillian or Sarah could totally help facilitate this project in any ways you need us to. But I think just sharing it amongst your clinical groups, against your, you know, with your community partners would really help us. And anything we could do to support that, please let me know.
Mm-hmm. I'm just going to tackle the two really great questions that were posed. Patients do not need to undergo a PCR test when they enroll. What we just are seeking is that they have done a test, and that they have some proof that they did a rapid test or a PCR test. The vast majority are rapid tests where someone does it at home, and that they did that. And then, but there's no further testing that's required. And then this is a really great question about molnupiravir. So we are unlikely to include it because our sister study in the UK, which is called Panoramic, actually answered this question for us. They are a study that has been up and running longer than us, and a number of their investigators are actually part of our team, and they've been helping kind of guide us. And they studied molnupiravir, and they found that it did not really have much of an effect. And I'll just put the link in the chat for those who are interested. And I see Benita also did that as well. That essentially it was exactly why these studies are important, because you take a medication that has some promise from initial studies, is very expensive, and then you actually put it in the real world and it turns out it's not really that effective. So Canada is unlikely to go down the molnupiravir route because of this study that was done. So and this is where international collaboration is really important. With this too, will be and we plan to try to pool our results with Panoramic so that we can together kind of answer questions around things like Paxlovid. So we're working really closely with them, but really great question.
Thank you. And I'm seeing a few more things come in through the chat as well. So people, again, just kind of talking about those barriers, saying that, you know, with the VET team ending on Friday, there'll be, you know, fewer community ambassadors. So, you know, again, the risk that there's a drop off of interest in the community. Some reference to, and I've also seen anecdotal evidence of this, that the rat tests are yielding a lot of false negatives, that maybe the effectiveness of rat tests has diminished with the new variants. I don't know, or maybe we're just not testing as well, using them as well.
I can speak to that. And something that I've been kind of mentioning is, one is that the rat tests are less likely to pick up because our immunity has changed. So because of both natural infection and vaccination, our bodies are now really good and better at quickly dealing with an infection. So if we have an exposure, often we all see that we have less symptoms. We're not having as many people, thankfully, you know, die and end up in hospital, but also our antibodies are quickly kind of sucking up the viral particles. So there's less for the rapid test to find and to show positive. The other interesting kind of thing is the way that we do rat tests. So on the instructions in the kits, many of you may have seen this in the news and stuff, that the kits often just say swab your nose. But now, since I would say probably about the last year or so with the Omicron wave, we recognize that the virus is often in people's throats more. So the way that we now try to counsel clinicians and patients to do the test is to swab your tongue and the back of your throat. And then with the same swab your nose. And that has increased the chances. So we still see people who, because they're following the instructions on the kit, are just kind of doing the very inside of their nose and not really kind of doing a full swab. But when we thankfully the kits still are fairly effective if people have, you know, a strong infection. What I've seen quite a bit too is where elderly patients whose immune system is not as primed and not as strong, they're more likely to have a positive rat. So you'll sometimes see in a family where the parents or the grandparents, they have positive tests, but the kids, they don't test positive. So it's maybe because young people's immune system are so, you know, strong, and they're suppressing it very quickly.
I have a related question for you, Andrew. What about doing it over several days? Is that recommended? You know, the kits have 5 test devices in them.
Yeah, it is a good thought. It's like sometimes we are seeing where someone just starts to have like a bit of a sore throat or sniffles, and they do just one test and it's negative, and they just assume that it's not COVID. And it is a good point to, people should actually continue to do a test while they're symptomatic, because we are seeing where initially it may be negative and then it actually shows that it was positive. In the case of this study, of course, we are seeking to engage people within the first 5 days of symptoms. So sometimes we are having people call us and it's been a number of days since their symptoms started. So we have to say, we're not actually able to engage you in the study. So that's where letting people know about the study and hopefully they're seeing it through posters and social media, and then their clinician at their primary care site, there's a poster in the waiting room. We also are working with the Alliance and other networks in Ontario to gear up to send out letters to patients where they would meet our criteria, just to let them know about the study and say, if you do test positive for COVID, please, consider joining this study and letting them know as well.
So for next steps for folks on the line, I know you went over it on your slides, Andrew, but do you want to just remind folks what to do next? I mean, please contact me if you don't know, if you can't remember anything else, and I'll make sure you get connected to the right folks. But Andrew and Gillian, do you want us to review the next steps?
Yeah, thank you. And first, thank you again for the invitation to present. Thank you all for being part of this. The first thing would be just to think about the website and think about that if you have any family member, client, yourself who is positive for COVID, please think of the study and consider bookmarking this. Another is we put in the chat our newsletter if you'd like to stay updated about the study. That's a great way. And we're just sending this out once a month to let people know what's the status and how things are going with it. And then if you would be at all interested in putting up posters and starting to let people know, and you'd like to do that, please let us know. Probably contacting Jen is a great idea. And I know that Gillian also put her contact info. If you think of any community groups, and you could, as simple as just sending an email from your list of your contacts and copying Gillian and just saying there's a COVID study that's happening. Please, Gillian will follow up. That would be great as well. We know that this is going to take a large community effort to make this happen, but the benefit will be that we are able to actually see what works to treat acute COVID, and also what works, if anything, to reduce long COVID. And also it's simultaneously building our capacity to do these types of primary care-led studies.
Thank you so much, Andrew. And I want to thank all of you, Andrew, Jen, and Gillian, for joining us today, taking the time to talk to us about this study and give us some tools to start helping to recruit people. I want to thank everybody who took the time to get up early this morning and come and join us for this. We will be sending out an email to everybody who registered with a link to the video, the slide deck, and the other links that have been shared, including the newsletter, that study from the Lancet. Anything that's been shared will be added to that email as well. So once again, thank you so much, everybody, for joining us. And please do keep an eye on your inboxes, and hopefully some of you will be able to help participate and get some clients participating in this trial. Thanks, everybody. Take care.
Thank you. Take care.